Good afternoon, ladies and gentlemen. Can I please ask those of you that may be standing at the back of the room if you could please join us a little closer. I always say it's wonderful to come from the African continent because we love to keep things close and talk to each other. So welcome, ladies and gentlemen. My name is Chipo Mutobi. I'm the Regional Director for GBCHealth based out of the South Africa office. I'd like to welcome you to I think the session which the reality of it is a huge challenge within our region. I think it's also a huge challenge globally. But today we're going to focus on two areas that really out of our region have really got a lot of political will behind. But also importantly, I think we are quite clear that we need a deepening of corporate engagement. But you know what? That's the rhetoric of what we're saying today. And I'm really saying it, and I'm saying it with tongue in cheek in that we really do not want it to be rhetoric. It cannot be rhetoric. It is really, really important. We tend to spend a lot of time, and we have these lovely sessions, and we talk. Well, I think I'm very proud to say that in my region, our politicians have made it very clear that the time is now to stop talking and to get the action going. But in having said that, I think I've also got to acknowledge that we've had amazing private sector engagement, both on TB and on malaria. And I'm really going to focus on those two. I think that, the conversations we're having over the 2 days are giving us a sense of all the other issues and aspects that we're looking at. So today we're going to focus on two critical areas in terms of TB and malaria. And, I always say the wonderful thing around being based in the offices that we are based out of Johannesburg, and I have to acknowledge Anglo-American for hosting our offices, and they've hosted our offices for 7 years, is that we also have a really strong partnership with the private sector. And I would like to encourage those of you that have got the patience to hear something exciting to join us tomorrow morning and hear a little bit more around the private sector engagement. But one of the key things we've done within the region is that we've also looked at ensuring that we're having collective conversations. And so the next session in terms of TB is going to be moderated by one of the content knowledge partners that we're working very closely with, the International Organization of Migration. Dr. Eric Ventura, I'm sure some of you do know Eric very well, is so passionate. We also share the passion for a club called Barcelona. But I see that in the work that he does all the time. And I couldn't have asked for a better stalwart than Dr. Ventura to moderate the next session. So I'm not going to say any more, and I'm going to allow him to let you know around what we'll be doing. And immediately after that, we would then move into the malaria elimination panel, and I'll come back and share a little bit more. Thank you very much. Ladies and gentlemen, Dr. Eric Ventura.
Good afternoon, ladies and gentlemen. It's a really pleasure to be here today, and especially to really strengthening the relation that we have with GBCHealth in our region in Southern Africa. So let me start by stress the fact that TB continues to kill 1.4 million people every year. Many of these in emergency economies. In Africa, there were 548,000 deaths in 2011. In this region is the highest region with the numbers of TB deaths. And also, Africa represents 40% of all total deaths globally. Of course, this situation remains a major obstacle to the economic development and to the fight against poverty. In Africa, HIV continues to drive the epidemic, with almost 60% of these deaths among people infected with HIV. However, the number of deaths also among HIV negative remains very high. More than 220,000 people died in 2011. And this, we are seeing that these figures are not declining since 2009. And if we compare with the figures in 1990, it's actually an increment of 10%. In the morning, we hear about the Millennium Development Goals. We have less than 1,000 days for the 2015 MDGs, and especially in TB in Africa region, we are very behind. Without accelerating efforts, TB will kill 4 million people between now and 2015. In Africa region, 5 million people will die in the next decade from TB and HIV if the status quo prevails. This is unacceptable, and because it's a preventable and treatable disease. It costs only $25 per person, the treatment, and you can cure the persons. With the advent of new technologies and a solid evidence base, there is a great potential to drive momentum towards ending TB and HIV co-infection. This will require, of course, an extraordinary effort, commitment, and collective action to accelerate a transformative regional and global response. It's very exciting for us to see the engagement of the private sector in this type of initiatives. And if someone was saying if HIV and TB, they managed to work very, very well to kill thousands of people every day, we don't see why the private sector and the public sector can join efforts and to address this issue. So let me start with before I introduce my colleagues from the panel, we have a 3-minute documentary from colleagues from areas. I think they are present in the room, so later also you can ask questions to them. So can you please put the documentary? Thank you.
90 years ago, we thought we had our answer to tuberculosis, the world's first TB vaccine. Then, a new drug, our cure. Then, we got complacent. Now, we have a global epidemic, airborne, contagious, deadly, and evolving into a superbug that's getting even harder and harder to treat. We're more exposed now than ever before.
MDR-TB is not like normal tuberculosis. I was resistant to 7 drugs. I can remember moments during treatment and thinking, I can't do this anymore. I don't know that I'll make it through this.
Every clinician is aware of the need for a newer vaccine, but then there's no option.
We must maintain this momentum because otherwise it will put us back decades, actually.
I'm appalled at the level of our complacency.
The number of people that have drug-resistant tuberculosis is going up, and nobody's talking about it.
How can I sit back when every 5 minutes a child is dying of TB? It would be criminal.
What we've got to do is not say, oh, we're going to make this a little better. We've got to essentially transform the entire field.
There is a small description in the table, so we are looking forward to see the full documentary. So I will ask my colleagues to join me. Lucica, maybe you can come here. Dr. Mpum Romatlen. So, you want to say it? Yeah? Yeah, otherwise you will have a thing. Okay, let me introduce Dr. Lucica Ditiu. She's the Executive Secretary for Stop TB Partnership. Yeah, I think otherwise we will have a... I have the microphone. It's fine. Yeah, you can.
Okay. Good afternoon, everybody. And allow me to start by, first of all, thank you all for being here with us. In the last 3 years, I think this is a unique opportunity that we have in having a Spotlight on TB event during the GBC meeting. So for that, I want to thank our colleagues from GBC, starting with Chipo, but as well the team from here, from New York. I want to thank Ray and Gary and Michael for their support. And of course, our host, Eric, and my co-presenters, Mpu and Renuka, that will become here on these nice chairs sometime this afternoon. You saw from the movie, and I think tuberculosis is something that we, our parents, our grandparents, our grand-grandparents are very familiar with. TB is something that exists with us for at least 9,000 years. And even though we have it with us for so long time, we find it very, very difficult to discuss about eliminating or going towards eradicating TB in this world. And it's the year 2013, and probably if Robert Koch, when he discovered the bacillus more than 100 years ago, would have think that along the line we are still discussing how to fight TB, probably he will not be extremely happy. But I'm here in front of you because I really believe that we can have a world without TB. And otherwise, I'll really see no reason why we are here, and I'll really see no reason why you have this interest in TB. The slides that I'm showing for you here, for those of you that you are familiar with tuberculosis, these are the slides that are showing the great progress that was happening over the last 10, 15, 20 years in TB. It's due to the very strong strategies that were put in place by WHO, very big investments in TB, a huge push by the Global Fund, who is funding more than 85% of the external budgets devoted to TB in the world. And these are the slides showing a decline in incidence, a decline in prevalence, and a decline in mortality, as you can see. But these slides as well are a reason for complacency. And let me explain you why a bit more. So you saw that the incidence is declining. The global TB incidence is 30 times higher than the one in the United States. If we want to go with the global level to the level of the United States, and if we continue to decline in the same rhythm as you saw in the previous slide, it will take us up to the year 2250. That's when, with what we have right now, and in the rhythm that we did in the last 20 years, it will take us to reach the level from the global level to the United States level. Even more, when we look at the mortality, you saw that there is a pretty sharp decline in mortality. However, as you already heard, there are at least 1.4 million people that are dying with TB. It's almost the entire population of Manhattan every year, and unnecessary, from a disease that is actually putting all of us at risk because it's airborne, and as far as we are breathing, there is nothing that can keep us from not getting infected with TB. The burden that we have, it's located into certain regions, and unpacking where do we have the biggest number of people dying, you will see that 40% of the deaths are happening in the African region, followed by the Southeast Asian region. And that's why we are having a special focus into the African countries, and the fact that this tragedy that is happening over there is due a lot to the co-infection between TB and HIV is due a lot to the fact that the most vulnerable groups that are affected are not having access to the services of treatment and diagnosis as they should have. The 75% of these deaths in the Africa region are happening in 10 countries, and they are part of the Southern Africa. Just to show you an example, this is the TB incidence at global level. One of the most vulnerable populations in the Southern African region are the miners. Some of you heard some discussions around TB in mining. As you can see, the levels of TB in the mining population is much, much, much bigger than in the general population. It's at the level of 2,500 per 100,000. However, going back to the global perspective, this is the number of cases that we are estimated that we are having every year, 9 million. This is as many that we are diagnosing and finding every year, just 6 million. This means that every year, 3 million cases are somewhere out there, quietly suffering, dying, and as well spreading TB. Because every single case that is not properly diagnosed and treated infects up to 10 other people per year. And from those infected, a certain percentage will become sick every year. You heard in the very nice documentary that IRAS put up about the superbug, about the MDR-TB. MDR-TB is a very special form of tuberculosis that unfortunately is another sign of what we human beings can do because it's a man-made created problem. MDR-TB is created when a program is failing in treating properly and with good quality treatment the patients or with the proper drugs. So there are estimated around 660,000 MDR-TB cases in the world. However, we are able, as you probably see, the little square of around 60,000 patients out of them are diagnosed and treated. The remaining, again, are somewhere in the world suffering and dying and infecting others. And that's happening every single year. And that's happening in spite of the fact that, as you heard, we know how to diagnose TB, we know how to treat TB, we know what it takes, and it's not even that expensive. So in terms of what we know with what we have right now, in terms of tools, we know that we can, by the simple integration of the TB and HIV interventions, which is something extremely simple and something that we speak for the last 10 years, the evidence is that in the last 10 years, 1.5 million lives were saved. We know that if we focus on the vulnerable and most at-risk populations, and we try to find those that are in need of the services, we can increase the number of cases detected by up to 25 times. And we know that by having communities engaged and having the services as close as to the clients as possible, we can double the detection and treatment. This can lead us very much forward and can help us in saving many, many lives. However, it will never lead towards elimination of TB. And in order to really change the tide, we need new tools, and we need much more funding in research and development. We have some hopes, and that's why I have hopes that we can eliminate and we can speak about a world without TB. There are breakthroughs with diagnosis. You all heard about the Gene Expert, which is a Nespresso-like machine without George Clooney, but which helps, though, diagnosing TB in 90 minutes versus weeks before. We have the first new anti-TB drugs in the last 50 years. I don't know how many of you are aware. We, unfortunately, and for whatever reason, in TB, we didn't capture the attention and the enthusiasm of the drug companies to have the good luck of HIV, of having a pipeline, giving drugs much more often. We have a first one that came on 31st December 2012, in 50 years. But we have a pipeline that gives us hope, and it's coming. And we have at least 12 vaccine candidates in the pipeline. But we need much more. These are things to happen, but really to change the tide, we need to have a very steep increase in research and development. And we really need to have a point-of-care diagnosis, because GeneXpert is great, it's not really a point of care. It doesn't really work to the level of take it in the bush and have it diagnosis in a few minutes. We need new drug regimens for shorter treatment duration. For all of you not knowing, the normal TB takes 6 months to treat, and the MDR TB takes up to 2 years to treat. And it's very expensive. It causes a lot of suffering financially, because the treatment for MDR TB, it's up to $5,000, $8,000 per patient, but suffering in terms of human suffering, because it's the drugs, which are up to 19 per day, 19 different pills, cause horrible side effects. So it's very difficult for somebody to really stay enrolled in the treatment. So there are many needs that have to be addressed, but they are as well big opportunities. As you probably see, having a new diagnosis and having some new treatment coming in and learning much more about our epidemic, we know where we should intervene. But we need to be much more accurate, and we really need to push it forward. There is no reason today, with what we have right now, that we cannot find all the patients that we have, all the 9 million, find them and put them on treatment. And that will change a lot the transmission and the future costs. But there is no reason of not pushing, as I said, the funding for research and development if we really want to have the new tools that will really make the difference in TB. The Global Fund is, as I said, the biggest funder for TB as an external funder. In TB, we have this great, interesting phenomenon that we have a lot of domestic investments that are happening. We just need to make sure that we leverage the money that are going in the countries and ensure that the health systems are the ones that are benefiting and that we can build on each other. There is a gap of at least 4 billion for the last 3 years in TB, and that's why we are looking very much forward, or we are hoping to have a fully replenished global fund, because having not all this money will cost lives, and it will cost up to 1 million lives if we will not be able to have the entire global fund replenished just in TB lives. The dream that we have in a very short period of time between now and the end of 2015 is to be able to find all the 9 million cases and put them on treatment. And as I said, we have the tools that are needed for that. And this is how much lives can be saved with every single patient that is enrolled on TB treatment, that is enrolled on MDR TB treatment, or is enrolled on TB HIV. The vision that we have of a world without TB cannot be achieved without 3 things, and these are the 3 things that I want you to take home from here. The first thing is implement with what we have right now and scale up, scale up, scale up to ensure that those vulnerable and unreachable are found and put on treatment. Invest in TB research, because we didn't really have the investments that the other diseases have, and it is the time right now to do that. And the third is to try and get the business and the corporate minds in TB. We used to be a disease that was very medicalized, in which doctors designed strategies and advocacy strategies and communication. I think we need to have the corporate minds and the business minds in helping us in making a very solid business case for investing in TB and for scaling up. You will hear much more on this from my colleague Renuka from BD, because we are really grateful that we are able right now to get the attention of the private sector, and I'm very much looking forward in getting the attention of you here from the private sector, because in TB, it's the year 2013. It is a bit shameful that we still speak about tuberculosis in the year 2013, but I want to challenge all of you to say that you would like to see in your lifetime much less TB, if not eliminate TB. Thank you very much.
Thank you very much, Lucica. So if in the morning we hear location, 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 the epicenter of the epicenter is in Africa, in Southern Africa, and I'm very glad to introduce the next speaker, Dr. Ramat Lepeng. She's the former Minister of Health in Lesotho, and currently she's the Board Vice Chair of the Global Fund. Dr. Please.
Should I sit or should I? Thank you. I think you should have said I'm the outgoing Vice Chair of the Global Fund, because I'm really looking forward to that. However, I am the Executive Vice President of CHAI, Clinton Health Access, and I'm really delighted to be invited here to be part of this panel. Although we are not much of a panel, there are beautiful seats there, but we are standing on the podium, so that's fine. I really acknowledge the work that Stop TB is doing around conscientizing all of us around TB. And I have been part of the TB world now for a long time. We work together with the Ministers of Health of SADC, working together to try and get a common strategy around TB, because we realized that majority of our patients who were dying from TB. Majority of the people living with HIV and AIDS who are dying in Southern Africa are dying of TB. So the Ministers of Health of South Africa, Swaziland, and Lesotho got together and were directed by the Stop TB Partnership and the World Bank. The reason why we involved the World Bank is because we wanted to work with the big business, and we were very fortunate to get the attention of the Anglo-American. It's one of the biggest employers in Southern Africa, and I have to say outright, Anglo-American, for its people, is doing a fantastic job, because I have been to the mining hospitals of Anglo-American. I know the quality of care that they give that to their employees. Now, where is the problem? The problem is in harmonization of the treatment protocols in all these countries, and it's in the referral protocols of referring from the mine or referring from South Africa to Lesotho, to Botswana, to Swaziland, to Mozambique, to Malawi. That is where the problem has been. We all know how difficult it is to treat TB. One of the main problems is once you treat patients with TB, within 2 weeks, they feel better. We know majority of the people who actually acquire TB, apart from the people because of the migration, are indigent people, are people who don't normally care about themselves. So we had to figure out the best way to bring TB to the spotlight. Lucica mentioned that it's a bit of a shame in the medical world that of all the diseases, a curable disease has evolved and shamed the medical world to an extent where we are now dealing with multi-drug resistant TB, we even have XDR TB, and you most definitely will die from XDR TB. Again, we are looking at the diagnostic world, shame. The same way that, when we received Gene Expert, which was in December 2011, everybody rejoiced. But it is still very expensive. It's very difficult to get it to the rural populations, as Lucica mentioned. There's somebody here with minutes. I don't know what he's doing. I mean, nobody told me I can't talk for 2 hours. So we convinced our heads of state in the SADC region to sign a declaration that will force all of us to work together as a region to get, uniform treatment protocols, referral protocols from one country to another, because there's a lot of migration, and the epicenter, of course, is South Africa, which is the biggest employer in the region. The biggest mines are in South Africa, but that does not mean that we don't have mines elsewhere and the same problems elsewhere. But that is precisely what happened. And in March this year, we were in Swaziland again, together with, I was representing the Global Fund together with other big employers like the Anglo-Americans, all the countries that were represented signed a declaration to try and work together this time, actually, to also get resources, making sure that we are all working together towards elimination of TB. 1,000 days has passed. We need to come up with the concrete results. This year also is a replenishment year for the Global Fund. We all as a community have to work together. And we not only work together to get a proper replenishment for the Global Fund, but we have to work together to convince the Global Fund to change the percentage of TB in the funding model. I know Luchika has worked very hard to do this, and it is really very important because it doesn't matter how much we get money for HIV. For as long as our people continue dying from TB, we will not win this battle. I know my time is up because the gentleman is now just looking at me. But I want to tell you, working for CHAI, for Clinton Health Access, we also are contributing in our own way towards elimination of TB. We are working together with our partner governments. We are working together on the market space. And we know from our previous work in HIV that if we work together in these two regions, we are able to achieve a lot. We hope to continue working together with all of you as we move forward to, I think now we are left with 896 days towards, no, is it 800?
959.
959 days towards 2015, and we will be able to come up with tangible results when it comes to TB. Thank you.
Thank you very much. Let me introduce the last speaker, Renuka Gate. She's the Executive Vice President of the HIV, the BD and also the MDG Health Alliance TB pillar.
Good afternoon, everybody. My remarks will be relatively short, but let me first introduce the company I represent, Becton Dickinson, which is a 116-year-old company, a leader in the medical devices diagnostics field. Relevant to TB is the fact that we have the culture-based diagnostic system, which still is the gold standard for the complete detection of MDR and XDR TB. I hear you both loud and clear. It is a diagnostics dilemma. You said shame on the diagnostics industry. We take this very seriously in BD and are committed to bringing forth the point of care, true point of care solution to address MDR as well. Hopefully, we'll have more to share in the coming conference. But it is a super bug, not an easy product to develop. So that's I just had to make that comment because your comments are very true. BD also has several partnerships with PEPFAR, and I'm just coming back from a visit with South Africa and Uganda, and I have to share with you some very stunning data that we found as part of our lab system partnership program. In Uganda, the Ministry of Health shared with us that the training that we provided with on specimen tracking of TB, moving TB specimens from rural remote villages, identifying and mapping labs through a GIS program, actually enabled them to identify 14.4% of MDR TB in retreated TB cases, as opposed to what the World Health Organization estimated as 4.4%. And that was just simply bringing home the point that there is no good data in the TB world, which was also spoken by the previous speakers earlier. Given our relevance in the world of TB, Ray Chambers tasked BD to head up the TB pillar strategy for the MDG Health Alliance with a focus to say what can and should be done by 2015 to bring the TB MDG goals back on track. We collaborated with our strategic partners, knowledge partners, Stop TB, who are, I'd say, walking, talking experts on the subject of TB, and developed a TB pillar plan. I'll talk a bit about the TB pillar plan, but the TB pillar plan is so well aligned with the SADC declaration that the former minister just spoke about, where you're focusing on how do you address TB in parts of the population that contribute the highest TB deaths today, which is the continent of Africa, and you're hearing more in Europe here. What can we do? And if you look at the top 10 countries, high-burden countries in Africa, 7 of them, I believe, are in the SADC region, and most of these countries are countries where there are mining operations. So that kind of completes the picture and why the pillar strategy so heavily focuses as well on that part of the world. Yesterday, I was in a meeting with the mining companies and several other government officials who were part of that meeting, facilitated by GBC South Africa. And it was a real hopeful meeting, because here are mining companies saying, we understand the problem, we want to solve it, we want to be part of the solution, we don't want to be part of the problem. And here was the government saying, we welcome your participation, and as the Permanent Secretary of Mozambique, Marcelino, said, let's move from declaration to action. So the point of all of that update is to say that there's a great momentum, and the time is now to bring some hope to, and new strategies, more importantly, to address this very ancient disease. But what I learned yesterday was also very interesting. There was discussion about how when a miner walks from Johannesburg or travels from Johannesburg back to home country, let's say Zambia, destroys the TB record because he doesn't want to face the testing protocols all over again. We also heard that these testing protocols are very different in different companies, and there's no standardization. And so the point being, TB patients are lost. They're not tracked. And I'd say it's therefore not just a mining issue, it's a data mining issue. There simply is no good data because you don't track these patients in a systematic manner. Also, what we heard yesterday was the very compelling call to say young women who have extrapulmonary TB and pediatric TB are nowhere in the horizon in terms of focus, or there's not sufficient data to address this vulnerable population. And as a ministry official said, the silence status of this young women and children is indeed frightening. But there's hope. Anglo-American, and our speaker mentioned Brian Brink, who's the private sector constituency lead, is really passionate about bringing electronic data and records. That's a dream, but I think it's not really a dream. It soon can happen because we have support and interest from country governments such as Mozambique and Zambia, and early discussions on with Swaziland to say, how can we make this happen? I'm very happy here to kind of unveil the TB pillar strategy, really issuing a call to the fellow companies in this room to say, let's join hands, because the TB pillar strategy is very aligned with the SADC declaration and will focus on 3 areas. How do you strengthen national plans with strategic information, using corporate competencies to develop good plans, because now is the time. Global Fund is calling for revised funding models and new models of investment. How do we strengthen advocacy for this issue so that it's not a forgotten disease and it's always up and front there in terms of attention? And how do we look at bringing in innovative models and financing to high-burden communities? And one of the collaborations that Anglo and BD is in an early stage of discussion is taking a mobile container biosafety level 3 lab equipped with all the necessary equipment for HIV/TB screening into the high-burden communities in the Gaza province of Mozambique. Very happy to say that BD will provide seed funding to establish a secretariat with GBC South Africa to really take this program broader. We will identify 2 or 3 countries, create a partnership forum with companies to develop plans which will be unveiled in coming October. So now's the time. Just join us, and we hope to play what duly is our role in this fight against TB. Thank you very much.